Okay, well, I think we'll make a start. Good day, everyone, and welcome to pediatric teaching. I wanted to talk today about congenital heart disease, and we spoke about this a few weeks ago when we had the last talk, but last time I spoke about acyanotic congenital heart disease, and we spoke a lot about left to right shunts and left ventricular outflow tract obstruction, but principally left to right shunts. So ventricular septal defects and atrial septal defects and PDAs and other forms of left to right shunts. And today I wanted to talk about the other common type of congenital heart disease, which is cyanotic congenital heart disease. So that's what we'll speak about today. I hope you can all hear me. There's quite a few people online today, so welcome everyone, and we'll get started. As I say, last time we spoke, which was about 3 weeks ago, we talked about acyanotic heart disease, and that makes up 75% of all types of congenital heart disease. So we talked about left to right shunts like VSDs and PDAs and ASDs and AVSDs. And we spoke also a bit about left ventricular outflow tract obstruction as aortic stenosis and other things. But we're talking about today about cyanotic congenital heart disease, and principally, just like we talked about left ventricular outflow tract obstruction, we'll be talking partly about obstructed right ventricular outflow tract, so the pulmonary valve or the pulmonary infundibulum. And we'll also talk about the other type of cyanotic congenital heart disease, which is mixing lesions, where you've got mixing between the left and the right side of the heart. And so the oxygenated blood mixes with the deoxygenated blood, and therefore you get further deoxygenated blood going systemically, and that's why the baby or the child is cyanosed. And so we'll talk about those two types of cyanotic congenital heart disease, the two mechanisms, if you like, of cyanotic congenital heart disease today. And we'll also talk about pulmonary hypertension as another form of cyanotic heart disease. It's not congenital heart disease, or it can be, but it's typically an acquired problem. So we'll be talking about the child who's cyanosed, and typically when it's important to, just like it's important to know how does a VSD typically present, well, it's important also to know how does cyanotic heart disease present. And it presents in two major ways. The first one is the infant or the child who has cyanotic episodes. They may have been well before, but they start having cyanotic episodes, and they may have some underlying cyanosis, or they might be otherwise apparently well and have cyanotic episodes. And that might be any time from 2 or 3 or 4 months onwards to even a year or 2 of age, right? So the infant or the child with cyanotic episodes. And I want you to, when we're thinking about that, I want you to think more broadly than just, oh, this must be there for cyanotic heart disease, but think broadly about all the different causes of episodic cyanosis. We'll talk about that. And the second presentation, so the first one is as children get older, in infancy or in childhood. But the other presentation, which is also common, is the newborn who's cyanosed at the time of birth or soon after birth, in the first few days of life. And the reason why these presentations are different is because the causes of an infant with cyanosis are different to a newborn baby with cyanosis. The types of cyanotic congenital heart disease that cause these things are different. And we'll talk about that. So let's first start with the most common presentation of cyanotic congenital heart disease, which is an infant or a child with cyanotic episodes. So this is common. This would be a typical presentation. We've all seen children like this, I'm sure. A 4-month-old boy presents with seizures and collapse that occur while he's upset and crying. So this baby, this is a real story of a baby who was 4 months old, and he had seizures and collapse when he got upset or crying, or even when he tried to strain and have a bowel action. This was, he had a seizure. Otherwise, he was a normal looking infant. His pulses looked normal. He was only mildly cyanosed, very hard to tell. His chest sounded clear. He didn't have much in the way of respiratory distress. There was no hepatomegaly to suggest heart failure. But you could have thought he was pink looking or only mildly cyanosed, but when he was measured his saturations, it was 88%. So his saturations are down a bit. What do you think? I guess what I'm wanting you to think is broadly about the differential diagnosis of this. We could all jump to it, this must be cyanotic heart disease, but I also think it's important to take a step back and say, well, what else could be the differential diagnosis of such a child who presents with episodes of cyanosis when the baby gets upset. And the first one, I think you should, apart from cyanotic heart disease, the first thing you should think, well, is it a respiratory event or is it a cardiac event? And there are a number of types of respiratory events that can lead to episodes of cyanosis or problems with breathing, that they're respiratory in nature. So breath holding is one, and that sometimes occurs in babies who are like 4 or 6 months of age, and when they get upset, they cry and scream, and then they hold their breath and they become cyanosed. So that sort of thing could present just like this baby. Another one is aspiration. If a baby's got, recurrent aspiration, when they aspirate, they could become cyanosed, and that could be episodic cyanotic episodes. Other things like a seizure, the baby's having a seizure that leads to cyanosis because of airway obstruction or because of breath holding, or and so seizures, the baby might be having hypoxic seizures related to episodes of hypoxemia, or might be having a seizure and then becoming hypoxic. That's why taking a very detailed history is important, and examining the child is important. And then, of course, the one that you would think about first is, could the baby have tetralogy of Fallot? And tetralogy of Fallot is the most common form of cyanotic congenital heart disease, and it typically presents with these episodes of cyanosis when a baby becomes unwell. And so a child with cyanotic heart disease, with tetralogy of Fallot, will have cyanosis and desaturation, especially when upset. They'll have a cardiac murmur, and the murmur is typically of pulmonary stenosis, an increased flow across the narrowed pulmonary valve, not increased flow, but obstruction to flow across the narrowed pulmonary valve. And then they often have a characteristic chest X-ray that I'm sure you know. And then when you think about other episodic events where a baby loses consciousness, or they have a seizure, or they become cyanosed, or they have apnea, then also think, could they be having an arrhythmia? And episodic arrhythmias could cause this. So the point is, when you're faced with a child who's got, the presentation is episodic cyanosis, or episodic seizures, or episodic apnea, then you should think, could it be respiratory? Could it be neurological? Could it be cardiac? Could it be an arrhythmia, for example? Yeah. Just think broadly when you're thinking about this sort of thing, and almost entirely you can make the distinction between these different diagnoses, the differential diagnosis, just on clinical grounds, just based on the clinical examination and some simple tests like the chest X-ray and the ECG. So this was this child's chest X-ray, and so what can you see there? Well, when we look at a chest X-ray, we always typically look at the lung fields first. And I guess the striking feature of this child is that the lung fields look reasonably clear, don't they? That looks like there's some, you could be excused for thinking there's some patchy change in the perihilar region, but generally speaking, the lung fields look clear. You can see the left hemidiaphragm, you can see the right hemidiaphragm, you can see the right heart border, you can see the left heart border. And so the lung fields themselves look reasonably clear. So there's not much evidence, for example, of aspiration or anything like that causing these episodes of cyanosis. But what do you think about the heart? Well, I hope you can see that there's the shape of the heart is abnormal. It doesn't look, the left and right ventricle doesn't look normal, does it? And this is a typical boot-shaped heart of a child who's got tetralogy of Fallot. And sometimes the lung fields look even blacker than this. You don't have any interstitial opacities at all. The lung fields just look black, but this is clearly a boot-shaped heart. So it would support the diagnosis of tetralogy of Fallot. In tetralogy of Fallot, you've got, this is I think a good diagram of what tetralogy of Fallot looks like. Remember, there's Fallot tetralogy meaning 4 things. All right, there's a pulmonary stenosis, there's a narrowing of the pulmonary valve. This is the pulmonary valve here. And below the pulmonary valve, it's the pulmonary infundibulum. So all of that muscle is very thick. In fact, all of the right ventricle is very thick. The right ventricle muscle usually is thinner than the left ventricle, but in tetralogy of Fallot, you can see that the right ventricle muscle is very thick. The muscle below the pulmonary valve is thickened. And so blood can't easily get out the pulmonary valve because of pulmonary valve stenosis and because of this infundibular hypertrophy. And when a child gets upset, then they increase their intrathoracic pressure, and that reduces the flow. It causes spasm of the pulmonary infundibulum. So this closes over even more and doesn't allow blood to go forward through the pulmonary artery into the left and right pulmonary arteries. So therefore, blood preferentially goes through the ventricular septal defect. And the fourth part of the four parts of the pulmonary stenosis, the infundibular hypertrophy, the ventricular septal defect, and the fourth part is this thing called the overriding aorta, which just means that the aorta, the aortic valve, is quite close to the ventricular septal defect. So any of the blood that goes out the VSD can go straight up into the aorta. Some of it, of course, mixes in the left ventricle, but most of it goes straight up through the aorta. And what that means is that when you get obstruction to the pulmonary infundibulum, because the baby gets upset, they clamp down on the pulmonary infundibulum, no blood goes into the lungs, then the blood goes through the VSD and then out the aorta. So you've got blue blood going systemically, all right? Whereas it should be going through the lungs to get more oxygen in it to come back to the left side of the heart and then go out. It can't do that. So it has to go directly out the aorta, and it's a very poorly deoxygenated blood, right? And so you just need to know there's four parts to tetralogy of Fallot and how that affects the blood flow in a child who's got tetralogy of Fallot. These babies are normally not cyanosed at birth. If a baby has cyanosis at birth, it's usually not a tetralogy of Fallot. It can be, but it's usually not. It's more likely to be pulmonary atresia than it is to be a tetralogy of Fallot, where there is flow through the pulmonary infundibulum, but it's just a bit more narrow than normal. So normally the babies get cyanosed at about 4 to 6 months of age, sometimes earlier, and their oxygen saturation may be normal or it may be low in the first week of life. And then there are some babies that continue to have a normal oxygen saturation except when they get upset, and then other babies that have got a persistent obstruction to the pulmonary valve, they'll always be cyanosed. So their saturation will always be 88 or 85 or 80, and it'll go lower when they have these episodes or these spells. So they typically develop cyanotic spells in the first 6 months of life. Sometimes it's a long time before 6 months, and sometimes it's a bit after. And they have an ejection systolic murmur in the left sternal edge, right? In the left, typically upper sternal edge that radiates to the back. And that murmur is the blood flowing through the pulmonary, the stenosed pulmonary valve, right? They have less blood going through because some of the blood goes just directly out the VSD and into the aorta, but some blood goes through the pulmonary valve, and that causes the murmur that you hear. You don't actually hear a murmur of a ventricular septal defect in tetralogy of Fallot. Typically, you just hear the ejection systolic murmur in the pulmonary area. These babies often have cyanotic spells, and it's important to know how to treat them. You can treat them pretty well most of the time. Firstly, the baby's upset, so you calm the child. You might put the baby at the breast, ask the mother to feed the baby, because sometimes that just calms the child. Give the baby oxygen, although oxygen in itself doesn't actually help unless you've got blood flow going through to the lungs, but you should give the baby oxygen. I typically give oxygen, let the baby feed, give some morphine if you can, some intramuscular morphine, because that can just relax the baby and it settles the pulmonary infundibulum. If you've got an IV, and give an IV fluid bolus, because that, if you give an IV fluid bolus, it encourages blood to be going out the pulmonary valve if you can give an IV fluid bolus. They typically need a bit of a fluid bolus. And in the longer term, these babies should be on propranolol, because propranolol relaxes the pulmonary infundibulum. It causes relaxation of this part of the muscle of the right ventricle, and therefore reduces the cyanotic episodes. These babies, as they get older, usually assume a squatting position, but when they're just small babies, you can do this to them. You can just have them on their back and just push their legs up into a flexed position in a knee chest position, because what that does is increase systemic vascular resistance. It encourages blood to flow back to the heart, and you get less flow left to right through the VSD, and a bit more blood going through the pulmonary valve. So that knee chest position, and as the kids get older, they assume a squatting position. That helps them a lot. But in small babies that are hard to deal with, you often have to do all of these things, and just wait, just be patient by giving them some sedation, by giving them oxygen, by giving them a fluid bolus and the knee chest position. You can usually get them back in and pink again, or back to their normal saturations. A child who's got tetralogy of Fallot, you can tell by their X-ray and by their clinical presentation, but you also can tell by their ECG. Now, we went through looking at some ECGs before, but we were mostly looking at children who've got left to right shunts. And this is the ECG of a child who typically has a right-sided heart disease, all right? And so remember, we talked about how to read an ECG. The first thing you do is look at the rate, and the rate is the number of large squares, 300 divided by the number of large squares, right? 300 divided by the number of large squares. So in this case, it's 1.8. So the rate is about 166. So this baby has a tachycardia. We look for whether or not there's sinus rhythm, and we look for an upright P wave in lead 1 and lead AVF, and the P wave is upright, and there's a P wave before every QRS complex, so you know that this baby's in sinus rhythm. The next thing we look at is the P wave morphology. All right, remember we said that the P wave should be 2 millimeters high, no more than 2 millimeters high, and no more than 2 millimeters wide. And in this case, you can see that the P waves are quite peaked. The P wave is at least 3 millimeters high. So that tells us if you remember, that there's right atrial hypertrophy. If the P wave is more than 2 millimeters wide, then there's left atrial hypertrophy. But this peaked P wave suggests right atrial hypertrophy. Next, we look at the QRS axis. And remember, we said that it's the net deflection in lead 1, the net deflection. So in this circumstance, the net deflection is negative. It's it's minus 14. And you look at the net deflection in lead AVF, and the net deflection. So you count the number of squares down and the number of squares up, and work out what the net deflection is. All right. So if it's say 20 down and 6 up, then 20 minus 6 is 14 down. All right, that's the way you do it. All right, and similarly here, if that was, let's see, about 13 up and 5 down, then the net deflection is 5 in the positive direction. All right, and what we do is then draw a vector. All right, the net deflection in lead 1 is minus 14, and the net deflection in AVF is positive 8. And so then draw the vector and see where the QRS axis is. And you can see that typically in an adult, you remember the QRS axis is here in the left lower quadrant, but in a child, like a 4-month-old baby, you can sometimes have a normal axis being across the midline, right? Can be in this quadrant, but this is quite a marked right axis deviation, isn't it? 160 degrees, you can calculate from that, right? So this baby has a right axis deviation, and yeah, and then you can calculate whether or not there's any evidence of ventricular hypertrophy. And we said that you'd calculate the RV2 plus SV5 when you're looking at right ventricular hypertrophy. In this case, it's 19, and left ventricular hypertrophy is RV5 plus SV2, and in this case it's 28. And remember, you might remember that the threshold for ventricular hypertrophy is about 35 millimeters. So if there's not, if these don't add up to 35, then probably there's not at this stage right ventricular hypertrophy or left ventricular hypertrophy. And in this case, the child had right axis deviation, peaked P wave, so right atrial hypertrophy, but at this stage was quite young, so didn't have marked right ventricular hypertrophy. As the child gets older, the RVH gets worse and worse, you typically see. I won't go through this, but as I said to you, a child with a normal, an infant can have a bit of a right axis deviation, but if it's very markedly towards the right, like 160 degrees, you start wondering whether or not there's anything else going on, like a right ventricular dominance, like you see with the with Tetralogy of Fallot. It's usually not one thing on the ECG that gives it away. It's usually a combination of things. So that clearly this child has, the key things are that there's right atrial hypertrophy and there's a right axis deviation. And that is enough to say, well, there must be something going on with the right side of this child's heart. And that's consistent with the X-ray that showed a boot-shaped heart. So therefore the baby's probably got Tetralogy of Fallot. The complications of Tetralogy of Fallot are important because I guess increasingly as we see these children survive infancy, they start getting complications. And if you remember in Port Moresby just a few weeks ago, there was 2 children, I think, with cyanotic congenital heart disease who had cerebral abscesses. I hope they're doing well now, but that's a common complication of cyanotic congenital heart disease. And it's fairly easy to understand because when you've got cyanotic congenital heart disease, then usually you've got blood flowing through the venous side of the circulation, and usually it flows then through the lungs, and the lungs filter off any microparticles, and they might filter off microemboli, or they might filter off small bacteria that, say, even when you brush your teeth, sometimes you get a bit of a bacteremia. If you've got like some tooth decay, you'll often get bacteremia, and that goes through the venous circulation typically, and then it goes back to the lungs, and then for most of us, it gets filtered out in the lungs. But if blood is coming from the venous circulation and not getting to go through the lungs, and it gets to go straight up the aorta, then it can go straight to the brain. So you can have microemboli that go to the brain that might have a few bacteria on it because the child, brushed their teeth, or they had a dental abscess, or they had a bit of, infected scabies or something like that. And that can go straight to the brain and then develop into a cerebral abscess. So this is quite a common complication, as you know, from cyanotic congenital heart disease, but it's just important to understand why that these babies, these children are more likely to get cerebral abscesses. Also, the other reason is when you've got a hypoxic environment in the brain because of the baby's more cyanosed, then that increases the risk of having anaerobic bacteria. And we know that the anaerobic bacteria live in the mouth, so they're more likely to cause a cerebral abscess. And then sometimes with these children, they, in response to hypoxia, they have an increased hemoglobin, don't they? So their hemoglobin might be 15 or 18 or 20 or even 24. We saw a child recently with a hemoglobin of 24 with Tetralogy of Fallot. And those children will have hyperviscosity. Their blood will flow slower through their brain, particularly through the microvascular circulation of their brain. And so therefore, it's more likely that bugs can settle in the brain and cause an abscess. So for all of these reasons, children are more likely to have cerebral abscesses if they've got Tetralogy of Fallot. So if you see a child with Tetralogy of Fallot who has a seizure or has a fever or has signs of meningitis, then you should think, well, could they have a cerebral abscess, and look for that. This child clearly has a cerebral abscess. This child. When you've got a child with Tetralogy of Fallot, not with a cerebral abscess, but it's important to know how to manage them. I mean, most of these children can get through to an older age, and hopefully many of them to have surgery. So you need to teach the family how to do home care of cyanotic spells. I mean, to teach them about the knee chest position, teach them about calming the baby, putting the baby at the breast if they have an episode that they get upset. Have them on propranolol because that can relax their pulmonary infundibulum. I tend to try to make sure their hemoglobin stays around about 15. That's an okay level. But if it's getting up to 20 or more than 20, then I usually bring them in for venesection and reduce their hemoglobin so that they don't get hyperviscosity. And in their surgery. So most children these days with a Tetralogy of Fallot have a complete repair of their Tetralogy of Fallot. It used to be that we did a lot of Blaylock, Taussig, Thomas shunts, these shunts, but we don't do these so much these days. Sometimes children can have them, but increasingly, even relatively young infants of sort of 4 to 6 months are having complete repairs of their Tetralogy of Fallot, where they have a closure of their VSD, they have their pulmonary infundibulum shaved off, they have a repair of their mitral, their pulmonary valve, and that completely repairs their heart. There are some long-term complications, though, in children with Tetralogy of Fallot, even if they've had a complete repair, and that can be, they can get recurrent obstruction to their right ventricular outflow tract, and sometimes they can get the pulmonary valve, instead of being stenosed, can be regurgitant, and that can sometimes lead to the need for valve replacement. And they can sometimes get arrhythmias. And we've had some children from PNG who've had repairs of their Tetralogy of Fallot who've ended up with arrhythmias, and actually even fatal arrhythmias, sadly, later on, many years later. And so these patients need to be followed up to make sure they don't have an arrhythmia. So they, even after a complete repair, they need close follow-up. If they've had a Blaylock, Taussig, Thomas shunt, then it's important that they get followed up as well, because they are likely to need an upgrade of their shunt, an increase in size of their shunt, or hopefully they get a complete repair later on. Sometimes we call it a BT shunt or a Blaylock Taussig shunt. I would just recommend to you a very good movie or a book called Something the Lord Made, and it's about the cardiologists who first designed the Blaylock Taussig shunt, and why it should be called a Blaylock Taussig Thomas shunt. It should be called a Thomas shunt. Okay, if you look up that movie, it's a very good movie about why this a BT shunt should actually be a BTT shunt. I won't say any more about that, but it's a very good movie, well worth watching, called Something the Lord Made. Now, okay, so we talked about Tetralogy of Fallot, but I wanted to talk about, so that's the infant or the child with cyanotic episodes. I want to talk about newborns that are born with cyanosis, because this is another common presentation of cyanotic congenital heart disease, and they're mostly not Tetralogy of Fallot. That's very rare for a baby to be born with cyanosis and for that to be caused by Tetralogy of Fallot. But there are two sorts of neonates with cyanosis. The first one who's well at birth and then collapses with shock in the first week of life. We talked a bit about this the last time, because those babies can have a hypoplastic left heart or obstruction to the left ventricle, or they can have some other form of duct-dependent lesion that when the duct closes, they become cyanosed. But they also might have something else, like sepsis or like birth asphyxia. That can also cause this presentation. They may be okay at birth, but then they collapse in the hours or days later. And then there's the baby who's cyanosed from the time they're born. They come out, the baby's born and they're cyanosed. And of course, that we often see that as a manifestation of perinatal asphyxia, but the baby could have something else like pneumonia or sepsis, or the baby could have a transposition of the great arteries. And this is a TGA, transposition of the great arteries, is the common cause of congenital cyanotic heart disease in a baby who's cyanosed from day one of life. If they're well at birth and they're well for a few days and then they become cyanosed like a week later, that's not usually a TGA. It can be, but it's not usually. It's usually something else. I just wanted to talk about a TGA, a transposition of the great arteries, because you'll sometimes see these children in the nursery and they're cyanosed from the time of birth. In a TGA, the aorta comes off the right ventricle. So this is the aorta, the large vessel, and it's coming off the right ventricle, and the pulmonary artery comes off the left ventricle. So the great arteries are completely transposed. And so what that means is that there's what's called a parallel circulation. The blood goes out the aorta into the systemic circulation and back through the veins, but never gets to go through the lungs. The blood goes into the lungs and back to the left atrium and then back out to the lungs again. And so you have a baby that never has any connection between the left and the right circulations. Instead of it being in series, the two circulations are in parallel. If a baby's got that and doesn't have any other holes in the heart, then the baby will die in the first hours of life. But most TGAs aren't like that. Most TGAs, there is something else. There's a duct that's open and it allows a mixing of blood, or there's a ventricular septal defect. And most of them have a VSD. And so instead of just having the transposed vessels, they have a often moderate to large VSD. And what that does is allow the blood to mix completely in the two ventricles, and it allows some oxygenated blood to get systemically. All right. And so even though the baby is deeply cyanosed, at least there's some oxygen going to the systemic circulation that's come back from the lungs, because it comes back from the lungs and then goes across the VSD and out the aorta to the systemic circulation. So all of these babies that survive the first hour or so of life, they've got some mixing lesion, like a VSD or an ASD or a large duct, a large patent ductus arteriosus. But they do have cyanosis from the first hours of life that progresses over the first few days. They usually have a metabolic acidosis. They're often tachypneic because of their metabolic acidosis. And they're blue and they're tachycardic, and they have a strong right ventricular impulse because their heart's often hyperdynamic and pumping really hard. They often don't have a murmur, and that can be a bit of a trap where it's hard to make the diagnosis, because they often don't have a murmur with a TGA. But what they have, when you look at their X-ray, if you look at this X-ray, you might say that doesn't look too abnormal. But I want you to just look at the heart shape. And there's a concept called the egg on the side. All right. If you turn an egg, just like a hen's egg, you turn it on the side, then the heart fits into that space. All right. And this is an egg. I've just drawn an egg, but an egg on the side, and the heart fits into that. So if ever you see a baby who's blue, then think, do they have an egg on the side heart? Because an egg on the side heart is a classic for a transposition of the great arteries. And so usually based on the clinical picture, on the clinical presentation, on the clinical features and the X-ray, you can make a diagnosis of a TGA. The other causes of cyanotic heart disease, as I said, if a baby is reasonably well at birth, but then becomes cyanosed some days later, they could have a TGA, but they also could have just pulmonary atresia. And the duct is, in the first hours of life, is allowing that right to left blood flow that they need. If you've got no blood going into the lungs, then it's got to go somewhere. And usually it's through the patent duct. But when the duct closes, if you've got pulmonary atresia, then the baby will be deeply cyanosed. And similarly with the truncus arteriosus, they have complete mixing within the ventricles, and that they often need a duct also to get systemic flow. And so when the duct closes, they become cyanosed or go into heart failure. Don't worry too much about these ones. I think it's good to be able to identify the child who's got tetralogy of Fallot based on clinical grounds and the X-ray and the ECG. And it's good to be able to identify the neonate who's cyanosed, who might have a TGA based on the clinical presentation and the chest X-ray. It's useful also to know where the murmurs are best heard. And we've talked about this before, but I said, say, for example, with a Tetralogy of Fallot, the murmur is most likely in the pulmonary area. And I've just drawn a diagram of where the common murmurs are. So this is the pulmonary area, the upper left sternal edge. And you typically see, you need to get an understanding of what types of murmurs there are. So this is a ejection systolic murmur. It sounds a bit like that, all right? And this is if you've got a murmur like that in the upper left sternal edge, then it could be just a flow murmur. It could be an ASD. It could be pulmonary stenosis. It could be a Tetralogy of Fallot. And so it's good to know when you hear a murmur like that, well, what's the differential diagnosis of that murmur that's loudest in the pulmonary area? If you hear the same murmur over in the aortic area on the other side of the sternum, the upper right sternal edge, the whoosh, 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 then you should think to yourself, well, is the aortic stenosis? And if there is, then feel for the pulses and feel whether they're small volume, because in aortic stenosis, you'll always get small volume pulses and you'll get a narrow pulse pressure. There's a lot of clues when you put it all together, the clinical features, the blood pressure, the murmur, where it's loudest, where it radiates. If you hear a murmur loudest in the lower left sternal edge, then you should think to yourself, is this a VSD, ventricular septal defect, especially if it sounds like a pansystolic murmur. And I've drawn what a pansystolic murmur sounds like. It's not a crescendo, decrescendo murmur. It's just the same all the way along. Whoosh, 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 like that. It doesn't go up and down. It just goes continuously one sound all the way through systole. Right? If you've got a murmur in the upper left sternal edge, but it seems to be not like whoosh, 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 but is going whoosh, 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 whoosh. It's going all the way through systole into diastole, then that's a continuous murmur, or sometimes called a hollow systolic murmur, and that suggests a continuous murmur, like of a PDA. That's where you'll hear it, in the upper left sternal edge. And so I think it's good to be able to identify where the murmurs are best heard and just practice listening to murmurs. If this pansystolic murmur is best heard at the lower left sternal edge, then it's likely to be a ventricular septal defect. But if you can hear it best in the apex and the mitral area across in the axilla, then it's more likely to be mitral regurgitation. All right? And so especially in the older child who's got evidence of rheumatic heart disease, then look for a mitral regurgent murmur, or listen for a mitral regurgent murmur in the axilla. So as you get just more experienced at just listening to hearts and putting it all together, the clinical features, the clinical presentation, the blood pressure, the pulses and what they tell us, the murmur, and whether the baby's cyanosed or not cyanosed, when it first presented, the ECG and the chest X-ray, you'll be able to make all these diagnoses. Even you get very close to the diagnosis even without an echo. And I know we sort of think, well, we've got to do an echo and find the diagnosis, but we really should be able to make these diagnoses come closer. It doesn't mean an echo is still very important to make the diagnosis, but you can get much closer to the diagnosis without that. Okay, I'm going to stop talking about congenital heart disease now, and I'm going to switch to pulmonary hypertension. And I'm going to talk, the reason I put pulmonary hypertension with cyanotic heart disease is because children who've got pulmonary hypertension are often cyanosed, and there's lots of different causes of pulmonary hypertension. And I think it's important, it's actually quite a common presentation of children in PNG who have cardiorespiratory disease. And I think it's important that we become quite good at diagnosing pulmonary hypertension and knowing the clinical features of it. And so these children often have recurrent or persistent respiratory distress. So even after they get better from their pneumonia or their acute respiratory infection, they often have respiratory distress again and bring them back into hospital. They have oxygen desaturation, so they have episodes of often quite severe cyanosis, and at baseline they may be cyanosed, but in their episodes, their oxygen saturation is even lower when they're having episodes. They will often have hepatomegaly from a congested liver from right heart failure. So the pulmonary hypertension causes dilatation of the right heart, leading to high venous pressures, leading to pulmonary liver congestion, and they'll often have right heart failure. They're usually tachycardic, and they may have a very prominent right ventricular heave. When you examine the precordium, their right ventricle is prominently contracting, and they often have a loud pulmonary second sound, which I know you all know. Everybody says, well, they have a loud P2, but also try to understand all the other features of pulmonary hypertension. So it's not just basing it on the loudness of the pulmonary second sound, but you put it all together, all the clinical features together. The important thing about pulmonary hypertension is to be open to what the cause is, because there is many different causes of pulmonary hypertension, and so it depends on the age of the presentation of the child, on their background problem, as to what the cause is. And in a neonate, for example, the most common cause of pulmonary hypertension is persistent pulmonary hypertension of the newborn, or what's sometimes called persistent fetal circulation, where the pulmonary vascular resistance remains high when it should drop down over the first few hours and days of life, but it remains high because the baby's in a stress state, because they've had a hypoxemia or they've had birth asphyxia. So the pulmonary vascular resistance remains high, and these babies get pulmonary hypertension, and they shunt blood through their foramen ovale, and they get then blue. That's the most common cause of neonates getting pulmonary hypertension. Then there's the children that have a large left to right shunt, and so all the time the blood is going more from the left ventricle to the right ventricle, or through from the left side of the heart to the right side of the heart, and they get pulmonary hypertension because they've got such a high pulmonary blood flow. And that's a different sort of pulmonary hypertension, but over time they develop pulmonary vascular changes that leads to pulmonary hypertension if you've got increased blood flow. Then there's another type where there's obstruction to the inflow of the pulmonary veins. So if you've got severe mitral stenosis or obstruction to the pulmonary veins, then there's the venous pressure in the lungs, the pulmonary venous pressure will be high because it can't get back into the left atrium. And so the pulmonary venous pressure goes high, and therefore that causes pulmonary hypertension. Right? That's called pulmonary venous hypertension. And you can sometimes make that distinction on what the X-ray looks like. And whenever you've got a child who has pulmonary hypertension, you want to make sure that they don't have obstructed pulmonary veins. So that's where an echo comes in, to be looking at the pulmonary veins and making sure they're not obstructed. Pulmonary hypertension is quite common in the highlands, and it's common in children who have severe pneumonia, and they may have no other cardiac problem. And so making that distinction between the child who's got a structural heart disease and has just got severe pneumonia and chronic hypoxia is important. Usually these children get better. They just take a bit longer to get over their pneumonia, and you have to give them oxygen for a longer period of time to reduce their hypoxic pulmonary vasoconstriction, which is related to altitude, high altitude, and their pneumonia. And then there's babies that have chronic lung disease from like bronchopulmonary dysplasia related to their prematurity, or if they have bronchiectasis from TB or from HIV, then they can get cor pulmonale. Their chronic lung disease can lead to pulmonary hypertension, right? And then some babies have pulmonary hypoplasia. They're born with small lungs, or if they've got congenital diaphragmatic hernia, they're born with small lungs, and they can have pulmonary hypertension because of that. And then sometimes you get children who've got pulmonary vascular problems. So pulmonary emboli going to their lungs. I've got a child at the moment who's got a COVID-related pulmonary emboli, pulmonary thromboemboli, and that can cause pulmonary hypertension, acute pulmonary hypertension. And then there's some nutritional problems that can cause pulmonary hypertension. So vitamin C deficiency and thiamine deficiency, they can also cause pulmonary hypertension. So as I say, the causes are many, but mostly based on the clinical presentation and the clinical features, we can make a distinction. We can say it's clearly not this one, it's clearly not that one. And you can get a bit more of an understanding of what the cause of the child's pulmonary hypertension is. But I've just gone through all the different causes just so as you understand there's lots of different types of pulmonary hypertension that are relatively common. We can make the diagnosis. The key concepts are that if the pulmonary artery pressure is more than 20 millimeters of mercury, the average in a newborn or a young infant, then that's pulmonary hypertension. But sometimes it's actually the pulmonary hypertension is so bad that the pulmonary pressures are higher than the systemic pressure. So, you know, a 1-year-old's blood pressure is often about 90/40 with a mean of 60. But if their pulmonary artery pressure, the mean pulmonary artery pressure is 60 as well, then that's very severe pulmonary hypertension. Anything more than a half or 2/3 of the systemic pressure is pulmonary hypertension. As I said, sometimes pulmonary hypertension can be primary, that is an underlying intrinsic problem with the pulmonary vasculature, or it can be secondary to chronic lung disease or something like that. Sometimes we can make a distinction between pulmonary artery hypertension and pulmonary venous hypertension. It still causes the same problem for the children. They get right heart failure often. And no matter what the cause of pulmonary hypertension, it affects the function of the right ventricle. So you get weak, you know, the right ventricle is usually weaker than the left ventricle. It's usually thin-walled and it's usually smaller, but and so it goes into failure more easily than the left ventricle, even with the same levels of pressure applied to it. And so because the right ventricle is a weaker pump, you can often get right heart failure earlier than what you would otherwise. And anything that sometimes when you're examining these children with pulmonary hypertension, you have to be very careful not to distress them or upset them. And so even as things as simple as putting in an intravenous cannula can cause them to have an episode of pulmonary hypertension. So if I'm doing anything to these children, I give them a little bit of sedation to just relax them a bit, whether it's a little bit of diazepam or some ketamine or something. If I'm going to do something big for them, like do a procedure or put in an IV cannula, then if they get upset, then sometimes they can get worse. So just think whether they need a small dose of chloral or a small dose of diazepam before you do any major procedure. Small things, it's okay, but a major procedure that's likely to upset them, then think about the way to do it most safely. The X-ray changes are interesting in pulmonary hypertension, and I only show you these X-rays. This was a child I had with pulmonary hypertension recently, and I show you these X-rays because what we'd often say is we'd look at this X-ray and we'd say, well, there may be some perihilar lymph nodes. And I think it's sometimes quite hard to tell what's the difference between perihilar lymph nodes and what's large pulmonary arteries. And this child had a very large pulmonary artery from pulmonary hypertension. And sometimes it's just difficult to tell. We might mistake this and say, well, there's large perihilar lymph nodes, so the child's got TB. But in fact, this was pulmonary hypertension and with very dilated pulmonary arteries. In fact, the pulmonary artery was larger than the aorta. This is another child with pulmonary artery hypertension where there's a large left and right pulmonary artery. You can see these are the pulmonary arteries and the high blood flow, the high pressures in the pulmonary vasculature in the perihilar region. So you might look at this and say, oh, they might have TB because of the perihilar lymph nodes, but also think, could they have pulmonary hypertension? Yeah. Okay. I'm going to talk very briefly about how to diagnose pulmonary hypertension on echo. And I know we went through this a bit. Well, some of us you've gone through it with Dr. Kilalang and Dr. Alita. But as you know, there are four different views you can look on an echo, and there's two good views for looking for pulmonary hypertension. I just really want to touch on them today. I mean, there's the parasternal long axis view, right? there's the which looks at the heart in this way, and then there's a parasternal short axis view where you direct the probe towards the left shoulder. It's in the same position, usually the upper left sternal edge, but anywhere down the left sternal edge where you actually get a good view of the heart. But this is what the heart typically looks like. Know about this one in the parasternal short axis view, where you've got the left ventricle and the right ventricle here. And this is a good one for looking for pulmonary hypertension. And then you've got the apical four-chamber view. This is the other good one, where you put the probe on the apex, and the cursor goes towards the left shoulder again. And what you see in this is the four chambers of the heart, whether it's this way up or the other way up. And this is a good one also for looking for pulmonary hypertension. So the two good ones are the parasternal short axis view and the apical four-chamber view. They're the ones that you most need to look at when you're looking for pulmonary hypertension. And this is the parasternal short axis view and this is a child who had severe pulmonary hypertension. And remember, this is the left ventricle, and typically the left ventricle would be larger than the right ventricle, wouldn't it? But in this case, the right ventricle is very dilated, and the septum, you can see the septum is pushed across to the left side. And remember, on the parasternal short axis view, you should see the left ventricle on the left and the right ventricle on the right. But here's the left ventricle really is squashed, and the right ventricle is very dilated. This is very typical of severe pulmonary hypertension, right? In the apical four-chamber view, remember I said the apical four-chamber view is where you put the probe, the echo probe on the apex, and you direct the cursor towards the left shoulder. So you get to see the left ventricle on the left, the right ventricle on the right, and depending on whether you have it inverted or not inverted, then the ventricles will be higher than the atrium. And here in the parasternal, in the apical four-chamber view, you can see again the left ventricle should be much larger than the right ventricle, but here you've got the right ventricle being very large and dilated, and the left ventricle, you can't see it all, but it's not as large as the right ventricle. And so this is again typical of pulmonary hypertension, where the septum is shifted across to the left ventricle looks a bit squashed, the right ventricle is very dilated. Right? These are the clues I think that anyone if you practice doing echoes, you'll be able to detect some signs of pulmonary hypertension and put it all together with the X-ray and the clinical features and diagnose pulmonary hypertension. I'll just show you this. It's a CT scan, and I don't show you because we don't make the diagnosis of pulmonary hypertension with CT scans. But the interesting thing about this is the pulmonary artery. And you can see the aorta. This is a contrast enhanced CT scan. This is the aorta, the left ventricle and the aorta. And you can see the left ventricle is very small relative to the right ventricle. This is the right ventricle, full of contrast. And this is the pulmonary artery. And the pulmonary artery is much bigger than the aorta. Right? And so this is severe pulmonary hypertension, where the pulmonary artery is bigger than the aorta, and the right ventricle is very dilated, and the septum is pushed across to the left, and the LV is much smaller. Right. So the management of pulmonary hypertension is, first of all, to go through that process of trying to think what the differential diagnosis is. So make the diagnosis of pulmonary hypertension based on the clinical grounds, and then think, well, what's the cause of the pulmonary hypertension? Is it cardiac or is it respiratory? Is it acute or is it chronic? All right, is it just related to pneumonia and hypoxia and altitude, or is it something that's chronic? Is there some chronic underlying lung disease? And what part of it is reversible? I think it's always important to ask this, because usually in children with pulmonary hypertension, there's a bit of it that's not reversible, and there's part of it that is reversible. It might be reversible by treating the pneumonia, or it might be reversible by giving oxygen and treating the hypoxia, or it might be reversible by giving some nutritional supplements if the child's vitamin C deficient. I had a child who had severe, profound pulmonary hypertension, and it was only due to scurvy, just due to vitamin C deficiency, and treated with vitamin C. The child got better over about 2 or 3 days. It was remarkable how quickly the child went from nearly arresting from pulmonary hypertension to actually being so much better. And so sometimes we can reverse some aspects of pulmonary hypertension by doing simple things, giving oxygen, treating pneumonia, giving nutritional supplements like vitamin C or thiamine, treating the heart failure with diuretics, with sometimes captopril, and sildenafil. Think about the use of sildenafil. Now, sometimes sildenafil will be useful, and sometimes it won't be. And sometimes if you've got fixed pulmonary hypertension, then sildenafil won't always be useful. If you've got a large left to right shunt, it won't be useful, and sometimes it'll be harmful. So when you're thinking about using sildenafil, it's useful to have gone through the process of trying to understand what the underlying cause is, and would sildenafil work or help or not help. That's all I'd say. I can explain that a bit more. But usually when you start sildenafil, if it's going to work, it usually works in the first few days. And by work, I mean, it might reduce the amount of oxygen you need to give. It might reduce the degree of respiratory distress the child has. Sometimes it takes, a 1-week trial of sildenafil, but usually you don't need to go much longer than that to know whether sildenafil is going to work or not. But I'd try to identify the other reversible factors in pulmonary hypertension. Treat the pneumonia, treat hypoxemia, look for nutritional deficiency and treat that if it's needed, treat the heart failure, and think about the role of sildenafil in these patients. Okay, so today we've talked about cyanotic congenital heart disease. We've primarily talked about Tetralogy of Fallot. We've talked about and how it presents. We've talked about cyanotic heart disease that presents at the time of birth, so congenital heart disease from transposition, a TGA, transposition of the great arteries. And we've talked about the other causes of cyanotic heart disease like pulmonary atresia and truncus. And we've talked about pulmonary hypertension and the different causes of pulmonary hypertension, and how to make an assessment of a child with pulmonary hypertension and try to make the diagnosis and how to treat it, and how to manage the things that we can reverse. Yeah, so that's all I want to talk about. I'm going to stop talking now and see if anyone's got any questions.